nice to see you, Charlene. It's been a while.
Lots of has happened.
How are you doing?
Doing pretty well. The move during COVID has taken a bit.
Yep, I'm there with you.
Yep.
Yeah. We still feel like very new to the city. And then we're like, it has been 2.5 years, but
So where are you now?
we're in Philly. I think the last time we talked, I was already here.
That's what I thought.
We
Yeah.
were we moved November 2020.
Okay.
Hi,
Okay.
Elaine. Hi, Dottie. Welcome.
Hello, thank you.
It's great to see everyone. We have about 20 folks registered, so we'll see who shows up. I am going to share my screen here. Great. Nice to see everyone. Hello. Hi, Wanda. I feel like we were just on a call last week. It's so nice to get to see you so often.
Hi. Looks like people are coming on in.
Yeah.
Yeah.
We will get started in just a couple minutes. Wait for a few more folks to join us.
I will be hopping out at 8 o'clock for another responsibility. So it's not that I'm unhappy with the content.
Totally understand, Miriam. In fact, I'm even more honored that you took time to join us tonight. Make sure I can still monitor our waiting room here. It is great to see everyone. Welcome to our monthly virtual conversations here at Mennonite Healthcare Fellowship. This is really a time we wanted to create a more regular space in our lives as members of MHF to connect with one another and also to have meaningful discussions of questions, of issues that impact us in our practice and that kind of sit at what we think is our, I like to call it the zone of genius. The thing that MHF does well is where faith and healthcare intersect. And so we're striving to have these conversations in these places where faith and healthcare intersect. And one of the things that we're really excited about this year is different members of our board have sort of said, I want to bring a question or I want to bring a topic or an issue and are taking the lead on these conversations. So tonight, that person is Claire who I am guessing all or most of you know in some capacity, because Claire has been around MHF a lot longer than I have, and to some extent is co-responsible in a way with Joanne for even me knowing about MHF, because I used to live in Cincinnati and went to church with Claire for many years. So I learned about MHF through Claire sharing at Cincinnati Mennonite Fellowship. And this is a question tonight: how are Anabaptist healthcare providers perceived and or functioning as catalysts for social justice? That is on Claire's heart and is just something he wanted to bring to us and have a conversation about. I am starting these sessions with a reminder of what our mission is, because MHF is a mission-driven organization, and I think it's helpful that we remember this. What are we a part of? And that is that MHF is to be an interdisciplinary community of Anabaptist health professionals, which seeks to nurture the integration of faith and practice, to provide opportunities for dialogue on health-related issues, and to address specific needs through education, advocacy, and service. So I think tonight's session meets a lot of these pieces: the advocacy and service and education part, opportunities for dialogue, nurturing community, and integration of faith and practice. Well, I think many of you have met Claire. Claire is a board-certified chaplain who works in hospice care in Ohio and has spent many years abroad in Australia. So I think that is an interesting piece of Claire's journey and story. I have the fortune of doing some research with chaplains in Australia, and I always enjoy talking to Claire about it because Claire knows everybody in Australia who's in the chaplaincy world. So it's fun to have that sort of niche overlapping piece. Claire's very active in Cincinnati Mennonite, and Claire has also been active in a number of social justice groups and activities. Very recently, the Poor People's Campaign, and I know that Claire is going to tell you more about that. So I will leave that to him. And I am going to stop sharing now and turn this over to Claire for our session. Thank you all so much for being here. Claire, the floor is yours.
Thank you, Kate. It's really great to see such a nice crowd here on this screen. It's full of friends' faces, including a couple of people I specifically invited. I am kind of overwhelmed, really. I'd also invited some other folks personally who just couldn't come tonight because of other commitments, such as for example, my really good friend Lee Failer, who's a chaplain at Goshen Hospital in Goshen, Indiana, where I used to be the chaplain for 10 years prior to going to Australia. And his wife just had hip replacement surgery yesterday, so he's taking care of her. And I've had some other friends provide their apologies. So there's a lot of interest in this subject. And I'm really glad we're recording it. So that a few folks like that can watch this later. This is not a session that I'm going to be talking all the time. It's a virtual discussion as advertised. I do want to share some opening remarks and share a couple of stories with you to sort of stir the pot, you might say, and generate some thoughts. But I really hope that everybody here tonight can reflect on their own experiences and share specifically a bit of how you're working at integrating this whole idea, this whole practice of being holistic in our care for others, and not only caring for people, but caring about how our culture, our systems are working or not working, and how we can be catalysts for change, for justice, for social change. Just yesterday, before I realized how closely this topic and the timing of it would correlate with another commitment I made to work into a rotation at our congregation. I do occasionally speak there when the pastor asks me to, and we're in the middle of the Beatitudes. And the specific beatitude that I was assigned to speak on yesterday during my turn was, blessed are those who hunger and thirst for righteousness, for they shall be filled. And well, I began my sermon by saying, a lot of Bible, a lot of texts, different versions, kind of soften the actual words of Jesus, because if you look at the actual Greek text, it's specifically that word righteousness is actually can be directly translated as justice. Blessed are those who hunger and thirst for justice, for they should be filled. But then I went on to also bring into play in that Matthew chapter 5, verses 10 through 12, which actually kind of elucidate and highlight a little more about that fourth beatitude, because it talks about, blessed are you who are persecuted for righteousness' sake, who are reviled, who, in other words, receive opposition for being faithful. And that's actually part of working for justice, because if we're on the right track, we know we're going to have opposition. So I was posing the question, are we ever satisfied when we're working for justice? Do we really get filled? Do we ever arrive? Are we always satisfied? No, we're actually doing this work because we're not satisfied with the way things are. And that's what motivates me, because there's always something better, something important that we can do that really matters to make our relationships better, to make the world a better place, to make systems work. And my gosh, there's a lot that's going wrong in our healthcare system in this country. And all of us are either involved directly or very interested in how we can be involved in our healthcare. And this includes mental health care. It includes, physical, spiritual care, all of that. So tonight, I know from talking with a couple of you that are here, I know you have a similar vision and drive and some stories to share, and that's what I want to draw out. In fact, tonight, I told you what's happening yesterday. I want to tell you a story of what happened today, because this is fresh. I am of course, working full-time as a hospice chaplain, and in the cracks of things, I also pay attention to some of the confidential and important messages that are being shared on an app called Signal that we use in the Poor People's Campaign here in Ohio, and other states do as well. I've been involved for about 4 years now in the Poor People's Campaign, which is working very hard at systemic change and also nurturing those who are impacted by racism, by militarism, by poverty, by ecological devastation, by some of the crazy things that are happening, the moral degradation in our culture that's caused by what I call the religious right. All of that is actually really important foci of our energies in the Poor People's Campaign. And the national team was putting out a call recently for us to share with them the names and contact numbers of people that we know personally who are impacted by what's happening right now within the next week, when Medicaid, statewide Medicaid programs and SNAP programs are being curtailed because of curtailing of federal funds to the states after supposedly COVID is over. And people are being seriously impacted by this. And so I sent a message to our coordinating committee and said, look, we really don't quite have the right story. We need another good, we had a couple of stories, but they didn't quite meet the criteria for people who were already on these programs, but are sharing a story of how they've been significantly impacted. So one of the, and I got permission from Joyce to share this story tonight because she shared it with me in response, and she's on our coordinating committee. She's someone that I know personally. I've worked with quite closely. She used to live here in Cincinnati, and she's now moved to Middletown after she and her husband found a very low-cost house that was kind of dilapidated. They're trying to fix up, and they bought it. They scraped their funds together, and that's where they're living, so they can avoid paying rent. And she moved there. So anyway, here's Joyce's situation. Joyce is on our. These are the exact words I submitted today to our field team. Joyce is on our Ohio Poor People's Campaign Coordinating Committee. She's lost her benefits, her SNAP, and her extra help where Medicaid paid her Medicare premium and copays. She's 60 years old, and that brings her $997 monthly SSD check down an additional $170. And now she has to pay for all of her groceries out of that check. Out of that, she has $164.90 deducted for Medicare premiums. That's the standard deduction. That's deducted from my bank account every month because I'm on Medicare too, since I'm over 65. Anyway, she also has lost $160 per month in food stamps. So she's going to her weekly food bank at 6 p.m. this evening, where she will get 4 eggs, a couple of cans, some bread, and toilet paper because she really needs it. How many seniors can live on that with the typical rising costs of rent is my question. Anyway, she says she won't be able to see a doctor unless she's dying. This is a direct quote from her. She doesn't have the money to cover the 20% copay for Medicare. Okay, that's a real life situation that Joyce shared with me just a few hours ago. This is what motivates me right now to lament, to put political pressure where it belongs, to help with that, not only at the local level, but at the statewide level. Another friend of mine who's on this this coordinating committee, he spent an hour last week on Thursday, the 16th of March, in Columbus at the State House, testifying about the impact of on some of his housing mates. He lives in public housing in Cleveland, and he's a very bright fellow, well educated, but he is living on the margins because of disability. And he knows from direct experience some of the stories of people who live in his building who are also going through similar things that I just described with Joyce. And he was there testifying about that impact to a committee that was supposedly listening to 2 hours of testimony made up of, I think, 4 Republicans and 2 Democrats, and a chair and 2 chairs, chair people, one from each party, political party. And when he got to testify, there were only 2 people left on that committee listening to anything. You know, it was a bit disheartening, but he was there and it was recorded. This is a sort of thing that's going on in all the states right now because they're working on budgets, you know. So anyway, we as medical people who relate every day with people who are dealing with health issues and crises, I mean, people who have to wonder whether they're going to buy medicine or food or make these difficult choices. This is all coming back now after what during COVID time was a little respite. from the pressures with the extra funds that the government was providing and are now being withdrawn. So we're going to see a lot more pressure and a lot more health disparities. I think we all know this, but what could I do as a chaplain, as a hospice chaplain? You know, I also get into homes. I not only visit folks in nursing homes, and of course in some very nice assisted living facilities and some very ritzy places. But, you know, just last week, I was in a hoarder's house. I mean, it was really bad. I was glad I had a mask on because if I didn't, I would have been sucking in some mold. I don't know what all. It was stank to high heaven. And there was a patient who was in his last days, and his wife who has dementia, and their son was introducing me to them. He feels bad about what's going on with his parents. He lives down the road in a very nice house, and they've been trying to take stuff out of that house, but the stuff gets noticed and they get angry because he's trying to take it out. But at least he got hospice in there. And I was working, you know, doing my thing compassionately as a chaplain relating to the patient. He died this weekend. I saw him 2 days before he died. And I did what I could, but I was really struck by the disparity between what I saw in that house and where I live and where his son's house is and what it's like down the road, and thinking about what could have been for that gentleman and his wife. Anyway, I'm going to stop talking now. I will come back into things, and I'd like to just invite you to share any personal stories of how you have been challenged, how you think you can make a difference and maybe are making a difference. I wouldn't call this a brag session, but I would like for you to share where you are making a difference, because we're inspiring vision now among each other. And there are some significant things that are happening. I mean, I'm looking at faces here on this screen where I know some very significant things are happening, and some people are rising to the challenge. So let's share some of these highlights and also lowlights that we've encountered, and spur each other on as to how we can address this question of the hour. Who'd like to go first?
This is Miriam Nafziger. I work as a registered nurse. I'm in an acute care setting, taking care of patients at the bedside. And the healthcare system is totally broken. Everybody in this this Zoom knows that. But I keep working at trying to change at least a little bit. And I'm thinking of two stories. Sometime with it, and my docs are fine, my hospital's fine. I'd still say if I need care, I go there. It's not them, it's the system. So we had a lady within the last month who came in and got a thyroidectomy done. So they did stick her on a synthroid medicine, but they wanted the endocrinologist to be able to review that before she went home. And there was such a commotion. They didn't know whether they were consulted and blah, blah, blah. And I said, well, we got to figure this out before she goes home. But of course, the system says we got to get her out this morning because of money. And then finally, they're ready to send them home. And the discharge nurse said, well, Miriam says, why are we sending her home? She has a blood pressure 170 over 110. Aren't we going to fix that first? So here I am working on all this. And then at some point I said to my manager something, and I don't know what he said. And I said, well, I just spent the last half hour trying to change the healthcare system, and it didn't go so good. But at least that lady got two things taken care of with the endocrinologist, and we fixed up her blood pressure. Just today, we tried to send a guy out. Now, I know he has some long-term, he has some COPD, but he came in with a bad heart. He had atrial flutter, and so they had to do drugs, yada, 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 cardio converted him. Okay, today it's time to send him out. Okay, the guy's wearing oxygen. Are we going to send him home on oxygen? He doesn't have it at home. They wrote the discharge order. The discharge nurse was going to send him, and I said, what are we doing about the oxygen? Oh, I guess we ought to deal with the oxygen. Well, all day I could feel like I'm trying to, anyway, those things I feel like I'm having to be looking at not just my nurse end. I feel like I have to be looking at the whole thing to try to preserve patient integrity stuff.
Wow. Thank you for sharing that story, Miriam. Miriam and I went clear through college together at EMC, as it was known then. And I know how old you are because I know how old I am, and you're still at it. My goodness.
I am 69. That's right. I'm still doing it.
Oh, that's, yeah. Anybody want to respond to her, or maybe you found yourself in a similar situation? Some of you are working in hospitals.
Hi, this is Wanda, and I will admit I've just realized how blessed I am. Most days I complain about being an academic. I teach nursing at Messiah University, but other days I do realize how blessed I am in that I can use these concepts in my lectures. My PhD thesis, I had to do a concept chapter, and it ended up on social justice. It's been a while, but one of the things that I try to bring in and explain with social justice is that this is not distributive justice. This isn't fairness. Social justice means that we work to decrease disparities, and so that sometimes we have to give up something, especially using my example as white middle class person. Yeah, I have to give up something so that somebody somewhere else might be able to move out of poverty or eat today, something like that. So for me, that has been a very important part of the concept of how you take this esoteric sort of concept and put it into the reality. Is what are we doing, and what are you going to do as working professionals then, as nurses, once you graduate, get jobs? What do you do on a daily basis to work towards some sort of social justice? So I'm not trying to brag or anything, but I realize that I am blessed that I have been able to bring this into our curriculum, and it's in healthcare professionals' curriculums, not just me. But to say, how do we do this, and how do we put this into practice? How do you find a way to put this into practice?
This is Wendy Schrag. I could share a little bit from a dialysis perspective. I've worked in the dialysis industry for 33 years as a social worker for the first 16. And now for the last 17 years, I work in our state government affairs department. And so I have 16 states that I do public policy for on the state level. And so I'm working on social change from a policy perspective every day. But one of our successes has been with our Medicaid patients. Transportation is so important. And with Medicaid, they have the benefit to get medical transportation, but so often the service is just so poor and so terrible. And we started having our clinics track about a year ago how many missed or shortened dialysis treatments they have due to transportation. And so I have that data now down to a clinic level, actually down to a patient level. And I have several states where I've started doing monthly calls with the state folks from Medicaid who oversee the transportation program, the transportation providers, and our social workers. And we're all on the call, and we see this data, and we can see the clinics that are having the most problems because of our data. So we're attacking it from a CQI perspective, and we're really making a lot of good progress. And so a lot of times I think you just have to try to figure out what is the problem, who needs to be in the room, and how can we solve it? And we're meeting every month. And we know each other now too. And so we're building those relationships, and it's just been a really good process. So that's something that's been really hopeful that I've been working on in a number of my states lately.
This is Reuben Chupp. I've been a chaplain at Goshen Health for, well, since 2018. I resigned from a pastorate. After 28 years in 2 congregations, I resigned from a pastorate 2018, July, and was hired that fall at Goshen Health, and I work with Lee Failer. And as a pastor, you walk with people long-term. One night I was calling, it was late at night, and they needed me to help settle down a patient. Obviously, she was coming down off of a drug fix and bouncing off the walls, almost literally. They couldn't treat her because she didn't want to let them to even touch her. And she was covered with debris, grass and leaves, etc. So I was pretty sure that she'd been sleeping outside and was likely homeless. And so I was able to settle her down enough so that they could begin processing, it's the only term I can think of, processing her at the hospital and trying to decide where to place her, because it wasn't bad enough to be hospitalized, but they couldn't turn her out on the street anymore either. And so I was with her for, I don't know, 2 to 2.5 hours. And I waited until someone came to pick her up, and they took her to a facility in Elkhart County. And as I was driving back home, I wondered, what difference does that make? Because I will never see her again, and I've not seen her since. And I've had to resign myself to being able to make a difference right where I am, at the moment that I am, with whoever I am, and then leave it at that. And I have those experiences just about every day that I'm either rounding as I come in to do a shift or as I'm called in. And that's been a difficult thing to get used to. But as I read the Gospels, I recognize that Jesus often had those one-off encounters with people and did what he could at that specific time. So it's been a really interesting thing to become accustomed to. The oncology floor, if I round through a couple of shifts, that's been another interesting experience, because often on the oncology floor, I become pretty aware as I ask nurses what's going on with a patient, that I may not see that person again because he or she is going to die. And I continue to struggle with that adjustment. Just being present for a given period of time, aware that I will probably not see that patient again. That's not always true, there are exceptions, but that's the norm. And just continuing to struggle with that, even since 2018, I've not quite become used to that. Knowing that sometimes, as some of you have described, we are turning patients back out into situations that are not good and are not life-giving and are not healing and do not bring hope. But the Gospels inspire me to do what I can.
Yeah, Jesus calls us to be his hands and his feet at that moment. And Reuben, you've had the blessing of being able to do long-term interaction. Now, like even on the cancer floor, I used to be a cancer nurse. And so you keep getting these patients back and you could develop relationships. But a lot of stuff in healthcare now we don't get to. But you never know, that lady with the grass and all that you sent out, maybe 2 years from now, she'll come in for something and you'll make rounds and she'll say, I remember you. I've had that happen just this week. I had a lady say, oh, I remember you the last time we were in here and you were a good nurse, so you'll be okay. I didn't remember her from anybody, but she might remember that. You never know. And Jesus knows. That's the other side, especially when I was working with cancer people and they're going to soon die. They don't get to tell my manager whether I'm good or bad because they go on and die. But Jesus knows whether I gave him a little extra pudding to eat or not. He knows whether I did something nice, and he knows what you did too, Reuben.
Well, Matthew 25 is really helpful. You know, the story about the least of these, or the parable. And, you know, there is tremendous power in just listening to somebody's story. Because I can't fix anything, but just listening to somebody's story for that moment in time, for that window in time, not knowing what the terminus is going to be, I keep telling myself that.
Ruben, I can relate to that as a chaplain, although I had the immense privilege for the vast majority of my time as a chaplain. I was in a very long-term care unit where the kids always came back to that unit when they came back. So I was able to build long-term relationships, but I had to wrestle with the same questions you're asking, as a chaplain, and also as a foster parent, with kids coming in and going out and coming in and going out. And had to really wrestle with this idea of God is calling me for this moment or this period of time. Sometimes an undetermined period of time. Sometimes I think my shortest kid was 9 hours. And I didn't think it would be 9 hours, but it was 9 hours. A very short period of time or a long period of time. And that sense I had that I realized was my own pride in a way, not in some big sinful way, but of feeling like I had to be involved. I had to follow up with that patient. I had to stay in this child's life. I had to do all these things. And there's a sense of responsibility that's healthy, but I realized that I was not actually letting there be room for God to be the one really following this person through their life. Or I was struggling to trust that God was the one writing these stories and taking care of these patients far better than I ever could. Even though it seemed like, sending these children or these patients back into homes and places that were really concerning, just having to trust that God sees deeper and broader than I can see.
Yeah.
I think that was a real turning point for me. I sometimes had to say, God is a much better parent than I am. I think that I have to stay involved, but God is a better parent, and God is writing a better story than I can. I mean, it's hard because we do see some stories end in ways that feel very tragic, and so it's hard to have that trust when you've had those losses of patients, of whoever it is, but there's still that hope even in those stories, and I just have to think about that. And then I said goodbye to a patient. I was very, very sad because I didn't think she was going to make it. It was a little kid who had a very rare cancer. I said goodbye to her and they discharged to hospice. And then a year later, I was at a completely different hospital who was on my patient list, but this family. And so they worked with them for another year, discharged back to hospice, didn't think she was going to make it, moved across the state. A year later, had a totally different, yet a third hospital who was on my patient list. So sometimes you never know. You just never know. So I like to think about that too. And that child, by the way, has overcome the odds.
Yeah, Kate, thank you for that reminder. The other thing I have to say to qualify my comments is that sometimes the reverse is true. I see parents parenting their parents and taking exceedingly good care of them, loving them, extending grace, doing whatever they can. And I know that patient is going to exit the hospital and go back into a really healthy, life-giving situation.
Amen. I'd like to invite Wendy, Chapel Dick invited her to this meeting. She's doing something significant that I think we should all might be blessed to hear about. So Wendy, come on into this discussion. You have to unmute. There you go.
Ah, there I am. It's a miracle. I'm no longer on mute. I am delighted to find this group. I just found you on Facebook, and a few hours later, Claire was talking to me about it. And we were Facebook friends. We've been Facebook friends for a long time. So I'm new to this, and I'm very excited. I am a CME provider. And I've been getting CME for 17 years through institution, but now I'm off on my own. So this is a new business for me. And I've really been studying what are called the core competencies for a physician, because you can get CME for this. And some of the core competencies are leadership, which includes ethics, which includes systems thinking, which includes the ability to look at a community and find resources beyond your office. A core competency is communication, which of course is a challenge when you have such a very short period of time. But teaching doctors emotional intelligence, teaching doctors how to listen, these are skills. You don't just get born with them. You practice them and you learn about them. And when do doctors ever do that? So I'm planning a couple of men's retreats at the Hermitage that I call Listen for physicians. Another core competency is DEI, diversity, equity, and inclusion. And this is becoming mandatory very quickly across the states. And so how do we teach that? And how do we teach it to people who are coming at it from very different places, especially in rural areas? It's so interesting. If you look at the AMA, they call racism is basically called urban issues. Well, we know in Ohio anyway, that racism is not an urban issue. So we are starting to do DEI trainings in my little town of Bluffton, Ohio. And it's just been really interesting to see the responses. And even though I read about how this is such a trend and everyone's doing it, the hospitals around here are not doing it. They certainly are not. And one hospital has just hired someone to recruit doctors who are people of color, but they have no DEI program for the existing staff. So how is that person of color going to enter that community and meet an incredibly undereducated population who has no sense of what bias is and what their own privilege is? So we're just at a really interesting crossroads, and the medical field is reflecting what is going on in the culture around us. A big part of DEI is understanding pronouns and what do you do with a transgender teenager. So, these kinds of learning curves are very steep. And just because someone is a doctor doesn't mean they have somehow a head start on any of this. They have the impulse to be self-sacrificing, to care for the patient, to serve, and to be a caregiver. They are taught that these are values in medical school, but the hows and the practicalities are never quite included in the syllabus. We need Miriam and other nurses to teach those skills.
Well, and the other problem with that is these poor doctors, the expectations of what they are supposed to be performing in one day conflict directly with the things that you're talking about, which are essential for good care. What the patient says and what the doctor hears can be two very different things. Some lady wrote a book about that.
Well, the AMA has made a priority to try to fight burnout. That they've named this a crisis. Doctors are quitting, especially women, at much higher numbers than men. And they have toolboxes, they call them, for helping with preventing doctors from quitting. And the toolboxes have some really good resources that really surprised me. One that I like a lot is how to stop doing stupid stuff. Just trying to help people in whatever system they are in figure out ways to not do as much as possible so that all your focus can be put to the places that it needs to go. So even though we are in a broken system, the AMA acknowledges that, and we still have to somehow teach resilience and survival skills the best we can within that and stop doing the stupid stuff whenever possible. I do want to mention that one of our first programs is happening in Lancaster, and it's being organized by, I believe his name is Marvin Hedrick. Does anybody know Marvin? His daughter, Emily, is an expert at compassion fatigue. And so her dad, who's a chaplain, organized this training for chaplains on compassion fatigue. And now that Emily's training also is certified to give CMEs, we can offer that to physicians. And so we've opened it up to be chaplains and physicians together, studying compassion fatigue. And the neat thing about Emily's workshop is that the attendance in the workshop is therapy. It is considered treatment for compassion fatigue. So it is set up to help provide resilience, even as you go into an existing stress. And it's not something you then go out and get more therapy for. You're done. You did it. You went through this experience together and you did a therapeutic agenda to help prevent compassion fatigue. And I really love that. I am actively looking for people to teach these skills to doctors and to nurses, because our CMEs can be used by any healthcare providers, nurse practitioners, physician's assistants, etc. And so if you know people who are who would be excellent at teaching burnout, DEI, communication, please don't hesitate to let me know. Because once I can get someone's workshop accredited with CME, that can be done an indefinite number of times, and it can be recorded and put online, and many, many people can benefit from that workshop in different contexts.
That's exciting, Wendy. And one of the reasons I wanted you to come on here is because I know there are people here on this screen in this room together that can potentially be help and resource to you in the ways you just described. I see people here who are retired, recently retired. They have learned how to be resilient. They can do this sort of stuff. So there you go, folks. You've got a challenge on your hands. And Wendy, put your contact details in the chat so we can let people get in touch with you.
Thank you.
And that is really making a difference, you know, especially as a chaplain. From my perspective, one of the key things is that that I've been taught and have practiced when I worked 20 years in the hospitals, especially, was that if you take care of the staff, you're taking care of the patients as well. Any other questions or comments for Wendy?
It's good to see you, Wendy. It's been a long time. I think you're so on with the compassion fatigue and caring for the caregiver. There's so much when we talk about the brokenness of healthcare systems that we don't have control over. And I'm one of the retired chaplains, by the way. I retired last April after 35 years, 25 years in acute care hospitals and such, and about 10 years in hospice care. The last 4 years or so I've been in hospice. So got to see a lot that we couldn't manage. And I think some of the best workshops that I attended that helped me to endure this long in chaplaincy were things that were related to self-care, compassion fatigue, understanding that, and it's kind of the story that Ruben shared a little bit earlier, just, you know, that we do a small part, and we do what we can with what we have, and we do make a difference. I have often been surprised, and even was recently very surprised by a staff person, or a person who was a nurse at the hospital I served in Westerville, St. Anne's, surprised me, come up to me and said, "I remember you." And I said, "You do? From where?" And just, you know, shared how during one of her more difficult encounters with a young woman who was dying in the ICU, that I was there for her as a nurse and walked alongside her during that process, and just supported her, and it was, you know, it took me, that was like 15, 20 years ago. Took me a while, but it kind of came back to me, and just those little things we do as chaplains not little things. They're not little. Those things we do as chaplains to walk alongside staff, families, patients, all that have such a huge impact. And we need to keep sharing those stories and finding strength in those, because we do, and I think we're going to see more challenges with the social justice kind of things with healthcare. That's not a real popular thing right now, social justice, at least in many circles. And so it's a difficult task, but yeah, glad to see all these faces on here, some that I haven't seen for a while.
Great. I think you bring up something really important. I find it sometimes easy to have conversations about social justice with patients. And yet the other providers that we're working with are also often struggling in many, many ways. And back to Claire's kind of opening example, I worked for Ascension Health for about 9 months, doing research on food insecurity in their employees. And it was unbelievably high. So many nurses, nursing assistants, these are folks with pretty good jobs at a hospital, were deeply food insecure, and it was really impacting work performance and levels of anxiety and their own healthcare usage and needs, and just huge issues with diabetes and other things. People really told me they know how to eat healthy, but they can't afford it. And that really was a moment for me, because I've worked in hospitals for years and I don't think I ever realized how widespread some of these justice issues are, even for the staff I'm working with every day. And tellingly, I turned in that report and Ascension let me go. So I don't know what they thought I was gonna find, but I turned in a report saying you've got to do something, because this is untenable and it's just relying on, your employees are not eligible for SNAP benefits because you pay them just over the line. But you don't actually pay them enough to make up for not having SNAP benefits. So they didn't want to hear that. But that really opened my eyes to how many justice issues are happening, even with all the colleagues I work with every day.
I was
Oh, go ahead.
I was taken back by a news report just this week that was telling the results of research that has just come out, showing that the role of racism in healthcare quality and delivery. And it shows a huge study that even for the wealthy Black pregnant women treated at the same hospital by the same staff, that the Black women's complications and poor pregnancy outcome was worse than the lowest social status of white women. And this is absolutely, it's just awful. Same hospitals, same physicians, but if you're a different race, they showed that the outcome of the pregnancy was worse than the lowest income of whites.
I'm going to offer another piece. I've worked for almost 25 years as a chaplain, and now I'm living in a fairly rural area and was unable to get a chaplain position. I'm working in the patient accounts department at our local hospital. And in a similar vein of the story that Kate just told, I had worked in the chaplain position I had at one point. I helped facilitate the distribution of funds to employees who were struggling. And I'm now in a position working with billing, basically, and it includes staff, and it includes a lot of people in a rural setting mostly white people, but it's a tourist area where most of the services are provided by people who can barely afford to live in the city of Anacortes. And I've been struck once again how many people do not have as a part of their structure management, financial management skills. And so some of my calls end up including how to guide people with financial management. And then the navigation of insurance it's totally daunting. Spending a lot of time trying to explain things and knowing, just as I did as a chaplain. I mean, one of the two pieces of theology that were very much a part of my life as a chaplain was turning over and letting go. And having to do the same in this kind of situation, knowing that there are going to be accounts that are going to head to collections. And as much as I've tried to work with preventing that, and then the impact that has on people's lives, it doesn't always result in people being able to work with the little bit of education that I try to give them to get out of that situation. But it's incredible, and it's big, and it's heart-wrenching. And whenever I can, I stretch the rules about payment plans and whatever I can do, and know that it's a drop in the bucket of what is needed for people to navigate just trying to get health care for themselves.
Thank you, Charlene, for sharing that in the way that you're really there in the trenches, working hard at just trying to make a difference. Are there any other stories that need to be shared? Some of you are pretty silent, but I know you have something you want to share. So this is your opportunity. Perhaps you have a question for one of us instead of a story. That's okay too.
Yeah, I have a question, Claire. During COVID, chaplains were routinely asked to go to nursing stations rather than patient's room and interact with the nurses and do chaplaincy work there. I'm wondering how many of the rest of you had some of that, or did some of that, and what was that like for you? How effective did you feel like you were trying to treat patients through colleagues on the floor?
Let's see. Am I the only one who might have been in that situation? I'm looking at who else here. Kate, yes, you were. I was in hospice work the whole time during COVID, and actually interacting daily with all of, variety of staff out in not only with patients, but I was never restricted except for maybe 1 month when we weren't sure what the rules were going to be for chaplains. But I think there was only about a month of time that I was not allowed to go visit patients. So I was fortunate in that regard. Of course, we trained in PPE and all of that. And I managed to stay COVID free all 3 years up until about a month ago when I finally got bit. But I didn't have very many symptoms, actually, even then. So I'm one of the fortunate ones. So I supported my team just normally. I wasn't in a hospital situation. I'm not sure who else here. I don't know quite everybody. Is some of you at the bottom of the screen there? I don't know if you're in a hospital situation or were chaplains or not.
I would say to Ruben, well, maybe those nurses needed it pretty bad. I'd have no objection to you going and taking care of the staff. Because if you take care of the staff, they're going to be able to take better care of the patients.
Exactly.
So I was a chaplain at Denver Medical Center for the first 5 months of COVID. And it was only about the first 2 weeks that we were limited in going into patients' rooms, but we also limited the amount that we went in because of the PPE shortage. We did a lot with various forms of technology, Zoom and Skype and so forth with patients. And so we did spend a lot more time with staff. Staff was extraordinarily stressed. I mean, if you just watching how an ICU just literally inside out and upside down in order to adjust to what it meant especially at the initial period, how to function. They needed as much support as they could get. And I really do believe that did ultimately benefit both patients and visitors, though the visitors were extremely limited during the period of time. The first 3.5 months were extremely limited. And that was a stress for staff as much too, because they were used to family being able to be there at the end of life. That was very difficult for staff.
Should have been more clear, Claire. We were not prohibited from going to visiting patients during that time. We were given the choice whether we would visit COVID patients, and many of the chaplains did. But we were asked, because of the stress that the nurses were under, to sometimes, I took a lot of night shifts. So I would come in at midnight after they had gotten themselves settled for the evening and read the charts, just to come in and go to the nurses' stations and to treat patients indirectly, as that way, as Miriam mentioned.
So how are you treating patients indirectly even? I'm still not following you.
Okay.
I'm kind of surprised that you couldn't do something like with technology or with the phone or with their families on the phone or on an iPad or something. Yeah, it just seems really strange, the setup that you had to go through here.
We did some of that. I did a lot of phone calls. I work, I'm part-time. I winter in Florida, and so I got assignments from the head chaplain at Goshen Health, a list of phone calls to make. So there was plenty of that too. What I'm suggesting is that treating patients through treating the nurses is that the nurses were, in my estimation, a lot of them were suffering from PTSD by about 6 to 9 months in, and it got worse. And so ministering to the nurses energized them in some cases to take care of patients when they were really dragging. The nurses were.
I see what you mean. When you were talking about indirectly treating patients, I thought you were telling the nurses to do something with specific patients on your behalf. Okay, that makes sense. Well, having a daughter who is an ICU nurse during all of COVID, I can attest to the PTSD. It was very difficult for her. I noticed a real change in her emotionally when she was able to get vaccinated. That just gave her a big sense of relief. I think she felt very vulnerable up until that point.
I will only jump in to say chaplains were kind of given very diverse kind of work assignments and how to do things during COVID. It was like no two hospitals used their chaplains the same way in terms of what they were and were not allowed to do. Some were told to do everything over the phone or over the iPad. Some weren't given the kind of credentials to do that. And so but there was a real shift, and this is actually internationally through some surveys that we did, a real shift to staff care during COVID, like a real realization by hospital administration, which is sometimes who counts, that chaplains had a role to play in caring for staff who were experiencing PTSD, et cetera. And what's been interesting is that hasn't shifted back. Now the problem is chaplains are being asked to do as much staff care as they did during the pandemic and return to their same levels of patient care. So a whole bunch of chaplains are like, wait a minute, I actually can't do all of this unless you hire more chaplains. So that's
I'm
kind of
going to
the
be ornery and say, join the healthcare. They do that to nurses all the time. You already got 5 patients. Let's give you 3 more.
Yep. So
Yeah, that's fascinating because I did my CPE in September of 2020. And so I learned to be a chaplain during the pandemic. And so staff care and patient care was built into what I was trained to do. And so I thought that was just standard. And so yeah, that's what I've been doing my whole career since I started, and continue to do.
there's
Adam,
an entire special.
Adam, could you share where you're working, what you're doing now?
Sure. Yeah. So I started, my internship was at Methodist Hospital in Arcadia, California, in LA. Arcadia is a little suburb of Los Angeles. And then I did my residency at Children's Hospital, Los Angeles. And then now I'm a staff chaplain at Cincinnati Children's Hospital. I've been there since August.
Thank you. Kate, what were you going to say?
Sorry, I was just going to say there is an entire special issue of the Journal of Pastoral Care and Counseling about how chaplains adjusted to COVID, and has some really interesting narratives about staff care. And then there's also an ebook that has 5 chaplains' journals that they kept during COVID. We asked them to keep the journals, so they wrote every week. They're really very moving. I like cry every time I read them. And I've read them a lot. So that's free. I popped that in the chat, and I'll put the special issue about COVID and chaplains is also open access if you're one of those people that like to read papers.
I was just going to say, if it's any reassurance to anybody, that in working with interprofessional education, which is again one of those things that is part of core values and healthcare curricula, we advocate for including a chaplain as much as possible in any kind of panel or approach that we're using at Messiah, and that's something that we're working on it. We're perhaps not doing as well as we could yet, but we're getting there. But definitely trying to keep the chaplains in the loop.
Well, I don't know how long we want to go tonight. We don't have to continue indefinitely here, but is there anyone else that wants to just contribute a thought or a question before we close our session?
There we go. I'd like to say one more thing, which is in keeping with the idea that workshops can actually be therapy in and of themselves. One of my goals is to hold our workshops in therapeutic and healing settings. And one of those is Camp Regenswald. And camp is now, after some conversations, they're open to offering CME for family camp, so that physicians or healthcare professionals don't have to leave their children, leave their family again, but could go to family camp and for a few hours a day, have a nice discussion, and at the end, walk away with the CMEs that they need. So if any again, if anyone is interested in serving in a camp setting and offering CMEs there, let me know.
Hmm. That's great. I was just trying to save the links in the chat that you put in there, Kate, but I'm realizing that my computer does not do control copy. What is the key to saving that chat? Can you explain?
I'm not actually sure that it's,
Does
I
anyone
also can't
know?
copy paste very well, but I can send it out to all of you.
That'd be great.
And I
I
can send
know
you any
there's some
information
kind
as
of
well.
keystroke combination that does record, that does let us save a whole entire chat at once, but I don't remember what it is.
Mhm. I would ask one last question. Am I allowed, Claire?
Yeah. I mean,
And that's what I call the MHF specific question, which is we have talked, and I think it's been really powerful about what Christian values impact how we see our role in social justice. And of course, Christian values and Anabaptist values are deeply overlapping, right? But I like to ask the question, what Anabaptist values, whatever branch of Anabaptism you belong to or are committed to, what are those Anabaptist commitments that help to fuel your care for social justice in your practice? What are those Anabaptist values?
Well, I'll
Good
go
night,
first.
everyone.
Oh, but no, you go ahead, brother.
Good night, everyone. My name is Tony Vasquez. For everyone who don't know me, I'm from Guatemala in Central America. A pleasure to be here. Sorry to get late into this beautiful meeting. I was listening all, and I have listened this question of Kate. I want to share an experience, perhaps going to try to answer the question of Kate and the others' opinions that everyone shares here. I was treating patients in the COVID area in the hospital where I work in. One of these patients was a high-ranking leader of the church, and even he was really strong in his faith. For 2 days, he was struggling for breathing, and we was doing our best we could to help him. And in opportunity, he said to me that God, he was spoken to him, and he was ready to go to the arms of God. And he asked me to pray for him. It's not a usually practice that I make, only if the patients ask me to do it, but it's not very often. After we pray, he getting a cardiac arrest, and he died. He passed away. Hey, the family definitely was really hurt about his loss, and they want to get inside of the area to put appropriate clothes to his father, and was a really difficult decision to make for me, because I know the contact he will be increase the risk of get contagious of COVID. So what we make a deal that they will get enter. I will help them with the nurses to put appropriate clothes to this leadership, and giving the opportunity the family to put clothes on him. and with the protection of adequate protection, so they get in, and we do this because I know once we put it just with the close of the hospital in the back of the dead people. So I believe this experience gave me the thought that we don't have a chaplain figure in Guatemala systems to give adequate companion to the patients and their families. It was a really hard experience for me, but a good experience in the sense that I put in practice my faith in there. And I I think was so unfair to the people during this pandemic. They don't have the opportunity to bury their deads, to have all this process, to be close to those who left us, right? So I think part of the values of the Anabaptist is that I think was fair there. I make a risk decision, even though, but a fair decision for the family to get close the, the people who are lost, because we lost a lot of humanity because we feared to get contagious of the COVID virus, and many people didn't have the opportunity to say the last goodbye to the loved ones, right?
Mhm.
Thank you for the time.
Thank you. Dodanim, you're from Guatemala and part of the Anabaptist community there, is that right? And you're a physician, is that right?
That's right.
I'm really glad you came on even at near the end of our time, but you shared a very powerful story there.
Yeah, thank you, mucho gusto.
Does anyone else want to respond to Kate's question? And then I want to respond as well.
Yeah, mainly because I haven't said much, but also because I think that I have helpful or just good nuance to interact with the question, in that I only converted to the Mennonite faith 7 years ago, but I've immersed myself pretty deeply within the Mennonite culture and Mennonite and Anabaptist theology, and attended a Mennonite seminary, and consider myself to bleed Anabaptist blood. But that said, I also didn't encounter the idea of social justice until I joined the Mennonite church. That was a completely foreign idea to me. And it's still kind of a foreign concept to me, because it often feels like talking about the oxygen around us. It feels like talking about the system that we're in, because it's in social justice for critiquing the system that we're within, and that feels so nebulous to me in a way that can be kind of hard for me to quantify. And so it's still all very new to me. I come from a world that focused really on itself, evangelicalism, and have become much more aware of salvation as an understanding of how I engage with the world, rather than something that's about a personal relationship with the deity. And so these ideas of Anabaptism and social justice are still kind of new. Where my Anabaptist theology engages with my work as a chaplain goes back to what Ruben said earlier that I really appreciated with the story of the sheep and the goats. And that idea does help me align myself with the concept of where do I find God and where do I find my convictions. And I find God, in the homeless person and at the bedside and in the prison. And to me, if you prove to me that God didn't exist, and the Bible's fully a man-made fabrication, that story would still be this ultimate truth that I would subscribe to, that would convict me to continue meeting with people at the bedside. So that's where that's my best engagement with that question that I can give. Hopefully it's a meaningful one for the group. Maybe not the best answer I could give. There is, before I close my thoughts, there's one other element to it. Just reflecting on things the group has said, and that's coming from California and especially in LA. I come from, after converting to the Mennonite faith, hearing about social justice a lot. At my church in Fresno, it really felt like something we just kind of lived. But at Pasadena Mennonite, it really felt like something we constantly talked about. And it felt like a competition, who could out social justice together. And that was kind of hard for me, because it just felt like I was never doing enough. And where I want to bring a little bit of nuance in, and hopefully not derail the conversation, just to bring a little nuance in, is I'm biracial, Mexican and white. And I grew up in an impoverished town. I'm the only person from the 8th grade, for my 8th grade class, to get a master's degree. 5 of the people I went to 8th grade with didn't graduate the 8th grade, and another 10 went to prison. So it's not, I don't come from an area where you would expect somebody to get a great education and excel at life, and so I feel like just fighting to have a stable life was doing pretty damn good. But then to kind of get there, and then just to kind of hear yeah, well, you're not doing enough because you're not going to enough marches, really just kind of made me feel really invalidated for the work I was doing, just to be one of the few Hispanics who actually graduated with a master's degree. And so I'm only adding that just because I feel like it kind of misses from the social justice conversation sometimes. Again, I don't want to derail the conversation. I hope I'm not. I hope that's a helpful engagement. Thank you for listening. I hope I didn't talk too long.
I appreciate that, Adam. Adam and I are fellow church members at Cincinnati Mennonite Fellowship, and we look forward to ongoing conversations right here locally. I wanted to share something to kind of close this out. You might have some things as well, Kate, to say, but I'm going to just wait a few seconds here to see if anyone else has something they really want to share. Well, I want to sort of finish off the story that I started with Joyce, who was describing her plight. And this directly relates to Kate's question. What's Anabaptist about our work, in trying to integrate or work for social change, social justice, whatever you want to call it. And what's Anabaptist about our vocation and how we go about being who we need to be. So Joyce took the courage today to share for the first time the details of her situation with our coordinating committee. through that private texting in Signal. She told us that my invitation to share stories finally prodded her to share her own. And there was a tremendous response from our coordinating committee to her. And I think it's going to really increase the sense of being a beloved community. You know, that is a term that is part of the Poor People's Campaign, but it's also biblical, and it's really a much broader concept that we hear about now, and I think is really apt for Anabaptist approach. How do we function as a beloved community in supporting each other? This meeting tonight is part of that. It's part of our theology and part of our ethos as Anabaptists to care for each other, to provide mutual aid, and to spur each other on, and to take care of each other's needs. Beyond, peace building and being nonviolent in our approaches and all of that, I think it's really central to be the beloved community. I'm going to, in my own situation, I just, within the last year, decided to let go of my primary care physician, who was only seeing me once a year. And I hooked up with a doctor's group that's based in a disadvantaged community section of Cincinnati that really reaches out to Medicare patients primarily, and mostly seniors. And I decided to link up with with that practice, and they have demonstrated to me the beloved community. They try to see their patients every 3 months. They wanted to see me at least that often, even more often, monthly for some of their patients. And almost everybody there is a Medicare patient. And they do good work, and they really take care of each other socially in the environment of when you come in. You really feel it. Last week I had my appointment, and it was just a routine checkup. And as I left the building, there were about 50 sacks of produce sitting out there at a table that they had organized to give a bag of produce, a pineapple, a bag of potatoes, and a bag of apples to every person who came that day to get to their appointment. Wow, that really impressed me. And it's just one little example of a lot of things that they do. I'm going to introduce Joyce to that facility, even though I don't know if they have a place like that in Middletown, but at least she comes back and forth sometimes to Cincinnati. But I'm going to introduce her to that group because it's not going to cost her anything for copays to be there. She can't afford the copays, but now I know there's a resource for her. And I haven't told her about that yet, but that's one little thing that I can do. And there's other people who are responding to her about some dental needs that she has and some other things that she shared. So within our own organization, and I really appreciated what you shared, Kate, about being aware of food insecurity among your own staff of that one place you worked at. That's exactly the kind of thing that we need to be about. Sometimes it requires being a bit prophetic to balance out the pastoral that we do. And we have to find that balance of being pastoral and prophetic. To just close out, I want to quote Bernice King, Martin Luther King Jr.'s daughter, who says this: Jesus didn't call it social justice. He simply called it love. If we would only love our neighbors beyond comfort, borders, race, religion, and other differences that we've allowed that we've allowed to be, I've got something obstructing my words here. I'll start over. If we would only love our neighbors beyond comfort, borders, race, religion, and other differences that we've allowed to be barriers, then social justice would be a given. Love makes justice happen. And I like that a lot. Well, Kate, what do you want to say at the end here?
Just mostly thank you for coming. It's always amazing to have this time together. Yeah, I really deeply appreciate all your perspectives. I would be remiss if I did not tell you about what's coming up at MHF. We will have another gathering for conversation next month. Elisa Troyer, one of our board members, will be helping to lead that. And I will, as always, help out. We also have an in-person opportunity a month from tomorrow. If you are near or drivable to Goshen, we'll have a full day of events from 10 to 2, though actually at 9 o'clock is an optional if you want to come and have coffee and pastries and just chat, no programming, but programming starting at 10 and ending at 2. Our annual gathering speaker who spoke at our annual gathering in the fall, but it was all the way here on the East Coast. So a lot of Goshen folks didn't get to hear her. She will be there, Melinda Berry. Then we're going to have a panel of later career healthcare providers reflecting on this same question. How have Anabaptist values and their faith played a role in their career? With some response and just time to get to know each other. So I hope folks can make that. You can register for that on our website. And then Dodanim is here. Dodanim and I have been working together. He has worked very, very hard to put together an 8-day experience in Guatemala to meet other Anabaptists. You may not know, but there are hundreds of Mennonite churches in Guatemala. Many of them are concentrated in one region, but I believe there's 8 or 9 churches in Guatemala City. Dodanim can correct us on that. And there are many Anabaptist health programs throughout the country. So we're going to be spending 8 days together as MHF folks, as well as folks from Global Anabaptist Health Network, learning about these programs, meeting other Anabaptists, and also seeing the beauty of the country. These are all pictures I took. Apparently when I was there, I only took pictures of churches. This picture of a weaving is like the only picture I have that is not a church, because there's really cool churches in Guatemala. So if you're interested in that, I would love to hear from you. We will be sending out the registration form later this week, and that is officially open for registration. And that's also through the Mennonite Seminary in Guatemala. So it's really cool because we can support them and they can house and coordinate for us. And that is all that I have to share with you, except please do consider becoming a member of MHF if you aren't. That is how we support programs like this. And yeah, we really appreciate your time, your attention. I am always available for follow-up conversation. And we look forward to seeing you in the future as well. Thank you all.
Thank you.
Thank you, everybody. Bye-bye.